Health Plans of America. In today's webinar is titled Improve Care While Lowering Costs, How Telehealth Helps You Better Care for Medicaid Members. Medicaid guidelines require that all providers practice telehealth within the scope of their State Practice Act. In addition, reimbursement for telehealth under Medicaid must satisfy federal requirements and is dependent on each state's unique payment methodologies. How can you navigate the Medicaid landscape of telehealth in your state? During this webinar, Brian Dees, Senior Consultant at Sellers Dorsey, will broadly discuss the telehealth landscape for Medicaid and specifically highlight unique opportunities in California, Texas, and Florida. He will review telehealth-specific Medicaid guidelines, including the State Practice Act, and explain the importance of satisfying federal requirements in each state for telehealth reimbursement under Medicaid. Danielle Rusella, General Manager of Payer Solutions at American Well, will share the impact technology has on Medicaid members and discuss how telehealth can positively impact quality measures and reduce costs for health plans. She will also share how some organizations are successfully utilizing telehealth to deliver better care for Medicaid members. American Well is a leading telehealth platform in the United States and globally connecting and enabling providers, insurers, patients, and innovators to deliver greater access to more affordable, higher quality care. American Well believes that digital care delivery will transform healthcare. The company offers a single comprehensive platform to support all telehealth needs from urgent to acute and post-acute care, as well as chronic care management and healthy living. With over a decade of experience, American Well powers telehealth solutions for over 160 health systems comprised of 2,000 hospitals and 55 health plan partners with over 36,000 employers covering 150 million lives. Feel free throughout this webinar to submit your questions located in the chat box located in the lower right-hand corner of your screen to be answered at the close of the webinar. And without further ado, I'll let Danielle and Brian take it away.
Hi there, good afternoon. My name is Brian Dees. I am a senior consultant at Sellers Dorsey. Our firm works on a variety of Medicaid finance and Medicaid policy projects. In my role at the firm, I'm part of our national consulting practice. I'm based in Austin, Texas. And I consult with a variety of clients on various Medicaid research-oriented projects, and I've had the privilege to work with the folks at American Well, who you'll be hearing from later on the presentation on some of this Medicaid market research. Prior to my time at Sellers Dorsey, I was employed for almost 8 years as a senior policy advisor at the Texas State Medicaid Agency, working on managed care, rollouts, and other special projects. Danielle, would you like to introduce yourself? Danielle?
Oh, can you not hear me?
Oh, no, I couldn't hear you.
Okay, I'm sorry about that. What did I not introduce myself?
No, I don't think we could hear you.
Okay, so I'll take it from the top. I don't know what happened there with my microphone. Hi, everybody. This is Danielle Rusella. I'm the president of our Health Plan Solutions organization at American Well. I've been in the role quite some time, having joined American Well almost at our inception about 14 years ago. I've worn a number of different executive leadership hats, with health plans really being at the core of American Well from our very early times. And over the course of the years, I've run, business development, international provider organizations, And in my current role, really working very closely with our health plan partners in their delivery and how they strategize, how they think about bringing a new model of care, an enhanced model of care to their membership. Their membership, of course, comes in all shapes and sizes, and we are doing it nationally across the board. I've, had the opportunity to work in the healthcare industry for the better part of 20 years. I've never worked directly with a health plan, or I'm sorry, in a health plan, but I can share I've partnered alongside with health plans in really every facet. And Medicaid in particular is not only fascinating to me, it's an area where American Well and where I am personally focused has such great applicability, and it's really my pleasure to be here today.
All right, great. Thanks, Danielle. Without further ado, I think we'll jump right into the presentation. What I'm going to do is give a general overview of Medicaid requirements around telehealth and telemedicine, and talk briefly about some of the opportunities in 3 states, Texas, Florida, and California. And so generally speaking, CMS, the Centers for Medicare and Medicaid Services, doesn't recognize telemedicine or telehealth as a distinct service, right? And so it's not a covered service that is a required or optional service under the Medicaid state plan. Rather, CMS views it as a modality that can be used to deliver covered services. It's viewed as a cost-effective alternative to more traditional face-to-face care, and states are really have flexibility under federal Medicaid regulations as to if they decide to reimburse telemedicine services and how they reimburse those services. Next slide. So as I alluded to, states can choose not to cover telemedicine. They can choose what types of telemedicine, where it can be covered, how it's provided, what types of providers deliver services, and how much providers are billed for services. That means that the general Medicaid requirements around comparability, statewide-ness, and freedom of choice don't apply to telemedicine services, which would mean that that states are not required to maintain an adequate number of telemedicine providers in the state. They're not required to pay telemedicine services in the same way that they pay for face-to-face services. They're not required to make sure that all beneficiaries in their state Medicaid program have the same access to telemedicine services. And so it really is left to the states, according to their Medicaid state plans and their regulations around scope of practice and around telemedicine, to determine how telemedicine works in each state. Next slide. And so states vary very widely in how they regulate telehealth services. A 2019 state survey from the Center for Connected Health Policy found that Medicaid programs in all 50 states and the District of Columbia reimburse for, at a minimum, telehealth services delivered through live face-to-face video. And so that's probably the modality of telehealth or telemedicine that we're all probably most familiar with. However, relatively fewer states reimburse for other modalities, such as remote patient monitoring or a store and forward that would collect data on at a patient site and forward it for review to a physician or other practitioner later. Place of service also in this survey was found to be a potential barrier to telehealth expansion, and less than half of state Medicaid programs consider the patient's home an allowable patient site. Next slide. In terms of opportunities, we've found that state Medicaid programs just in general are increasingly moving toward quality-based incentives and disincentives in their managed care contracts, and often measure plan performance on metrics such as HEDIS measures or potentially preventable events. And these quality requirements can provide an opportunity to leverage telehealth services, which for many of the HEDIS measures and indeed some of the PPEs could potentially be used to improve those scores and, depending on the incentive program operative in each state, potentially improve an MCO's bottom line. Next slide. So I'm going to give a brief overview now of 3 states that we took a look at. These are states that we found to be particularly fertile environments for telehealth services, in that they have fairly good regulations around, or progressive regulations around telehealth, as well as some levers at the MCO level that would allow telehealth to really be used to improve health outcomes, and indeed potentially improve financial performance. And so in Texas, the first state that we'll look at, has a fairly complex Medicaid managed care program with several different models serving different segments of the population, from Star Kids, which serves SSI and waiver recipients, to its Star Chip program, which serves the majority of TANF-related members. Texas has a significant presence of both health system-owned plans as well as national carriers. Next slide. Texas, as I mentioned earlier, recently has continued to improve upon its telehealth policies and regulations. According to the most recent updates, services are maybe accessed in the home, school, mental health facilities, medical health sites, state supporting living centers. A facility fee is not allowable in the home, but the home is an allowable site. Telehealth is a covered benefit for Texas Medicaid, but the contract, as it's currently written with the MCOs, does not require the MCOs to specifically contract with providers offering telemedicine. This is a theme I think we'll see in a couple of these other states, in which, while there's an allowance to cover a wide variety of telemedicine services, there are not hard requirements on MCOs to create robust telemedicine networks in the same way that they are with face-to-face networks of providers. In Texas, out-of-state physicians who are distance site providers may provide episodic telemedicine services. And we did find, in talking to folks, that the older requirements in which the home is not allowable site, still lingers, as it takes time to educate both providers and patients about the allowability of the home as a potential site for care. Next slide. So in terms of the managed care environments, there's mixed financial performance in recent years. MCOs are strongly incentivized by capitation withholds and bonus payments to improve their quality and experience of care, including reducing avoidable ER visits. Next slide. And so some of the opportunities in Texas because of that. One is to look at, and this can be driven by a variety of stakeholders, but to encourage the Texas Medicaid Agency to improve upon its telehealth requirements and contract, and really start to measure the availability and the use of telehealth by MCOs. That's not something that's currently reported on, and there are no provider network and provider access requirements specific to telehealth. So that's another metric that's simply missing, that could, if adopted, support the increased use of telehealth. And then, as I alluded to, there's a very clear opportunity in Texas for MCOs to leverage telehealth services to improve their HEDIS scores and do better in the state's paper quality program. Particularly, PPVs, or potentially preventable visits, are one of the at-risk measures. And we know that telehealth is particularly excellent at addressing those urgent care situations where someone might be tempted to go to the ER and could instead access telehealth services in the home. Next slide. Switching gears to Florida, Florida also has fairly telehealth-friendly MCO contract requirements, more clearly requiring MCOs to have and develop relationships with the telehealth vendors. We found that in the most recent round of procurements, all of the MCOs in Florida did have relationships and contracts with telehealth vendors. We did find that that although there are state regulations and guidelines around telehealth and telemedicine, there is recent legislation that failed to pass that would have clarified some of their internal regulations and would essentially stand to be improved in the next legislative session. Next slide. Florida, again, serves around 4 million people. They have a significant presence of large national carriers and several different managed care models with 11 different plans supporting its largest program, which is, again, a mix of national carriers and some local carriers. Next slide. Most of the plans in 2017 reported gains. But we noted that in terms of incentives and disincentives, there are provisions for substantial liquidated damages for things like failing to achieve network adequacy and failing to meet certain reporting requirements, and that managed care plans are eligible to receive an achieved savings rebate of 1% of revenue for exceeding agency quality measures. However, this seems to be very difficult to achieve. And there appears to be significant provider interest in telemedicine in Florida. Next slide. Florida doesn't currently have a capitation withhold or bonus structure, but there are public report cards in which star ratings, like many other states, are assigned in categories based on performance on HEDIS measures. And so while there is not a financial motive per se at the moment under the current contract to perform well on these HEDIS measures, it still does factor into public reporting and potentially decision-making for members around selecting a plan. Next slide. And so finally, focusing on California. California has been, I think we would say, a leader for many years in its telemedicine and telehealth regulations. It has allowed many of the modalities that are just starting to catch on in many other states for longer. Medicaid recently updated its policies, its internal policies, to allow almost all services to be delivered via telehealth and by either synchronous or store and forward communication. And so that's significant. Also recently, the most recent legislative session in California, which just closed out a few weeks ago, a bill passed requiring payment parity between services delivered via telehealth and face-to-face services. That's an innovation that we haven't seen so much in other states, but could be something important around the continued development of telehealth. Telehealth is a covered benefit for Medicaid, but again, like in Texas, MCOs are not specifically required to contract with providers. However, importantly, MCOs are required to report on the percentage of providers using telehealth. So, there is measurement going on, and as we know, measuring the prevalence of the use of services and of new modalities for services can really inform decision makers. And then we noted that if a provider is not located in California for the purposes of delivering telehealth services, they must be affiliated with a Medi-Cal enrolled provider group. Slide. So California Medi-Cal is I think the largest Medicaid program in the country, serving 13 million people. It has a rather complex system with the model of managed care determined by the county. And so there are several different models with a significant presence of the large national carriers, but also many smaller local plans that operate in each of these county-driven areas. So in California, the potential leverage point for telehealth is a member assignment or default policy that looks at MCO performance on a suite of quality metrics. And based on performance, plans are ranked, and that figures into the auto assignment algorithm for members who don't actively select a health plan. And so that is a potential area for MCOs to leverage telehealth to improve those scores and therefore get more members through the auto assignment. Next slide. And so as noted, the HEDIS measures that are looked at through the auto assignment methodology are in many cases addressable through telehealth. Things like comprehensive diabetes care, controlling high blood pressure, prenatal and postpartum visits, potentially are the kinds of things that we could improve rates of through telehealth and then improve those scores. Next slide. And that is it for me. So I will pass it off to Danielle to talk about American Well and the solutions they are offering.
Fantastic. Thank you again, Brian. And so we're just going to switch gears just a bit, and I'm going to spend the next 25 minutes or so just sharing a little bit about what American Well has been doing out in the market and the solutions we're bringing to bear specifically to Medicaid plans and Medicaid membership around the country. And so, hopefully you see a slide on your screen here. And if you're not familiar with American Well, we've built and delivered a platform to support a new model of care, essentially an infrastructure to allow digital distribution of health and wellness services. So, this isn't a slide to brag about logos, but rather a representation of our diverse ecosystem, all of whom are relying on American Well and this digital infrastructure I mentioned. Importantly, when you think about a lot of the logos that are probably fairly small on your screens, what's important here is that our clients own the brand, they own the member, they own the experience. American Well and our technology is what powers the offering inside. So you never see American Well, you see the brands. You see brands that your members and your communities know and trust and recognize. And for more than a decade, we've had the opportunity to work alongside so many of these organizations that are mentioned here on the screen, from the Anthems of the world to the Cleveland Clinics to regional hospitals and health plans. But at the end of the day, they're all interested in two very important things: improving clinical and financial outcomes. And never has that been more true than in the Medicaid space. And with Medicaid-focused plans. And if we move on to the next slide, I wanted to share a little bit about some of the plans that we are working alongside today that have a Medicaid, footprint in one shape or another. And these are regional health plans. These are national health plans. These are hospitals and health systems, and importantly, integrated delivery systems. And we work with all of them. These days, probably more than 4 million Americans, Medicaid Americans, are using and touching our technology in one form or another. And if we move to the next slide, what I can share with you here is, having worked with our partners for the better part of the last decade, but the last couple of years in particular, where, to Brian's earlier points around CMS and a lot more visibility and awareness, not only on the member side, but also on the provider side, about how we can really use technology and thinking about that as a new model and a new mode of care. And if you move to the next slide, what have we learned from our partners, over this time? We've acquired a great deal of experience, knowledge, best practices, and in particular, what is resonating with members and providers. And we've taken these learnings, and they're here on your screen. We're going to go through them in a moment, and we've learned really how we can perfect what we think is going to resonate, and in particular, how we can use telehealth as a way to drive down costs, as a way to engage members where they are, when they need care, as an opportunity to create and deliver programs that are really thinking about the populations that we're serving. When we think of Medicaid, it's not just one population, one vanilla population. It's new moms. It's those with chronic conditions. It's those that maybe Spanish speaking. It's those with a specific disease or specific needs. And we've got the opportunity to really focus and plug telehealth into so many different avenues. And so we know for a fact that we are addressing a variety of needs. Probably if I was looking at the slide here, the biggest couple of areas are network access around the country. We are seeing access as being an area where telehealth has been hugely effective because we are able to project and extend local networks, and in some cases where there are no networks. When we think of members who are often showing up inappropriately in the emergency rooms because they don't have this access, obviously this is an opportunity where telehealth can be hugely effective. And when we think about members that are frankly unengaged, they may be unengaged because of mobility, because of social determinants, because frankly, their access is an issue, and even making it easy and simple. And so it's an opportunity for us to really think about, again, using telehealth to address these populations. And if we move to the next slide, one of the questions I get asked, and we get asked quite a bit, is, how do you effectively bring a comprehensive digital health solution to your membership? There's a lot of considerations. There's often, many things that go into a successful program, particularly if you've not offered telehealth or online or digital tools. But hopefully you can see here on this screen, we've kind of narrowed it down to really 4 big key considerations. And these are the steps that we work alongside our clients to really think about how they bring their programs to life. One is the actual design. What should the program look like? This includes branding. This includes, what are the services that you're going to offer? Access is a key component to bringing your program to life. Are these going to be your clinicians, your own staff, coordinators, educators? Importantly, when you think of primary and urgent care and behavioral health services, if you don't have within your own communities and your own networks, where is access going to come from? Member engagement plays another important role. How are you going to communicate with members? How are you going to make them aware? It's an ongoing kind of a thing, but it's really important to understand how you'll engage with members. And to my earlier point, particularly members who haven't previously been engaged with you or engaged in other programs. And then you need to be able to track it. How do you know that you're being successful once a program is up and running? How do you measure it? How do you optimize it? How do you think about other aspects of the program to really drive adoption, to really drive appropriate utilization? And if we move to the next slide, this is where creating a very customized experience that really promotes your brand. I mean, you know best about your membership. You know what they look like. You know the issues that they face. And importantly, you know how they identify with your brand. So when you think about these things, it really does come to just, not only a simple and effective way to bring telehealth to your members, but importantly, where you really want to think about configuring it and really making it your own. It's an opportunity to showcase your brand, to connect in a digital way with your community, and importantly with your membership. And taking it a step further, really customizing services around things that you are well known for, existing programs you may offer, population-specific programs, and even areas of specialty that may come from within and also in affiliation and association with your community and local networks. And if we move to the next slide, we can get a better sense for, well, what does this actually look like? You know, we provide our clients with the added ability to create specific programs and services around unique population needs. You know, whether they be, you know, new moms, managing chronic conditions, extending existing programs and services. If you see here on this screen, this is an opportunity to really think about very unique and diverse ways in which you can curate an experience that is very personal to the member. What's that do? It far will enhance member engagement and the experience that your members will have. It will make this a lot more personal and more specific to them and where they happen to be in their journey. It will give you an opportunity to attract and retain members, offering digital ways to access and provide care in a convenient way that can be, you know, at home, in the workplace, in the community. This is a significant attractor and retention tool. And then importantly, when we think about even expanding provider network adequacy, your own local providers, your own clinicians, we think of some of the programs that we can create together. Not only do they drive value, they can really deliver more out into the community and to the providers that you might already be working with today. So if we move to the next slide, we can get into this a little further. Two of the programs and ways that we think about services that really can drive value are around behavioral health, and in a moment I'm going to talk about, you know, ED diversion. But on the slide in front of you, let's spend a little bit of time talking about, you know, what most of, you know, this audience is probably quite familiar with, the high cost of behavioral health. And when we look at behavioral health, we know that members, if behavioral health services, mental health providers are not readily available in the community, are not available or made easily available by the health plan, then members are left to their own device. And when left to their own devices, they show up in extremely high cost settings, typically the ER. We see more claims being submitted for someone having behavioral health conditions because they've got nowhere to turn. And they are less likely to adhere to their medications and typically, if untreated, have higher mortality rates. And we know that nearly 2/3 of people with mental health issues also have medical conditions. So it's a very expensive population, and it's a population that we know well and that we can get after. And we'll talk about that in a moment. So let's move to the next slide. When we think of telehealth, there's no better application for it than when we think of behavioral health issues. Having the ability to digitally offer behavioral health services coupled with a robust network of mental health providers allows us to dramatically improve outcomes and, importantly, drive down costs. We can even lend our behavioral health expertise and, importantly, our clinical staff called Online Care Group, which I'm going to talk about in a subsequent slide. We can even take our network of behavioral health expertise and we can provide adequacy to your community providers, often many of them who are lacking that skill set or who have, who have the ability to really treat mental illnesses. So, there's a lot that can be done here, and depending on the nature of not only the individual, but what they seek, we can really wrap around an extensive program that really thinks not just about therapy, but psychology and psychiatry as well. Taking it a step further, if we move to the next slide, we do look at behavioral health as a program, really a program that envelops the member and considers a lot of important factors. Member choice in the behavioral, this is a slide that builds, you're gonna need to click a couple of times here so we can get the full visual on the screen. But when we think of a program that really envelops the member, we have to think of things like choice. the member actually choosing the provider that they're going to have a relationship with. This is not just initially for maybe assessment, but it's an opportunity because we know typically behavioral health visits are not one. They are typically a series of 4, 5, 6 times. And so the member choosing who they're going to have a relationship and an interaction with is highly important. We also know that convenient conveniency is convenient access, and the ability to schedule appointments with a provider that I'm comfortable with, or that looks on screen someone I want to have a relationship with. There's got to be an opportunity to have a highly coordinated experience. Thinking, we've got the ability through multi-way video and other ways that we can coordinate care, including the local primary care provider. And importantly, quality oversight. We've got, staff and quality programs that we include in all of the services and programs that we wind up delivering. And when I share with you a little more about Online Care Group, I can talk with you about the clinical leadership, the programs, the guidelines, the protocols, the training, the staffing, and the quality measures that really go into the clinical service we wind up delivering. Moving on to the next slide, I mentioned another important area when we think of the programs that we want to be able to roll out, where we really think telehealth plays a role, again, particularly for Medicaid members. We know that high ED utilization is an issue for many plans, particularly when access and adequacy fall short. We know, and there's a lot of data. We won't have we'll have a chance to look at an example or two, but we realize that that in order for members to not show up in the emergency room, we've got to provide them with an alternative. We've got to provide them with access. We have to provide them with conveniency. We have to provide them with tools and technology to make this incredibly easy, so their first stop when thinking about non-emergent issues, which is often the case when someone shows up in the emergency room, we have to give them an alternative for them not to show up here. And if we move to the next slide, this is actually a slide that shares how one of our partners, Nemours Children's Health in Florida, is after, this slide is depicting how patients who've had a visit on their platform, when they were asked what would they have done if they didn't have a telehealth visit today, we collected data and got a really some really good insights on, if they didn't have telehealth, what would they have done? And you're going to see some of the data on here. Obviously, they would have shown up in higher cost settings, and also in some cases done nothing at all. So this translates to real savings for the plan from moving those low acuity visits to lower cost settings, as well as savings to the overall healthcare system, leaving the emergency room available for higher acuity patients that need to be seen immediately. And if we move on to the next slide, this is another example, a client of ours, Pediatric Associates. And, this is another example of them creating a very successful ED diversion program. And they are one of the largest primary care pediatric practices in the state of Florida. They've got about, 500,000 lives, approximately 55 or 60% of them are covered under managed Medicaid. And one of the things that they were trying to do is really divert and figure out how they could move unnecessary in-person care to primary care offices and emergency departments on to telehealth. And the results are astounding. We don't have the opportunity to get into them. They're shown here on your screen, and we're happy to make this case study available to you. But what is so astounding is that in the first 4 months of the program, Pediatric Associates reduced ER usage by more than 60%, just in a pilot population of about 145 patients. And that included, roughly, 100 families that were high ER utilizers. And they also incorporated a device from TytoCare, which is a device that can be used in the home that can really allow, you know, a parent to capture vital signs, look in the ears, look in the throat. It almost is like the provider is there, you know, with the child. And so this just creates yet another example of not only driving down costs, but a really intimate, impactful experience. And if we move on to the next slide, I mentioned earlier that one of the things that we've been able to do when we think about access, we think about adequacy, we think about extending our clients' and partners' own networks, is really coming to them and bringing them our expertise in two important areas. And the one on the right is the most important, which is we've got a commercially known as Online Care Group. This is our separate clinical affiliate national telehealth network called Online Care Group. We operated in all 50 states, more than 3,500 providers and growing. And it really is a network that's dedicated to extending your networks, your local community providers, your local networks, your own clinical staff, with a predominance of urgent and family pediatric care, a growing network of therapists, including psychiatry, and other areas of specialty, particularly around nutrition and lactation. And it's a network that our partners have come to rely on in a number of different ways. But when we think of, again, adequacy and we think of access, it's an organization that really can help you when you think about the access that perhaps is not happening and is not readily available in the community. And if we move on to the next slide, we can talk about, you know, we have tools and capabilities that you can extend to your own network. We know that in addition to your own clinicians, that you've got community providers, you have local providers, and they are a very big part of this equation here. And so we've developed a whole suite of automated tools that can enroll and onboard and really incorporate your own providers to extend themselves online. And it's a great tool, and it's a great way that you can go in your community, include your providers in online care for the members that they're likely already seeing or perhaps not seeing enough in their own brick and mortar practices. And if we move on to the next slide, this is a great example of Blue Cross Blue Shield of Massachusetts, right here where American Wall is headquartered in Boston. They've been a client and partner of ours for a number of years. And this is, they've done a whole case study on this. It's a fascinating case study about how Blue Cross Blue Shield of Massachusetts was really thinking about, roughly 4% of their network that were submitting at least one claim for behavioral health services. Yet, these were providers that weren't engaged online. And for Massachusetts, it was an opportunity to take these capabilities and put them in the hands of their behavioral health providers out in the community. And Blue Cross Blue Shield of Massachusetts Member Service Department was roughly getting about 1,600 calls a month from members looking for behavioral health services. So when you think about addressing barriers and for really, the ability to promote behavioral health provider adoption of telehealth, Blue Cross really began to think about how do they put this tool and these capabilities into their providers' hands, because obviously, the community is looking for their services. So it was an opportunity to really have them increase the number of reimbursement codes, structure a program so that network providers could easily deliver virtual care on the platform that Blue Cross Blue Shield of Massachusetts was delivering, develop incentive programs to really help address reimbursement levels. And so they worked with their provider community in not only rolling out a program, but thinking about cost, thinking about reimbursement, thinking about provider engagement, and really easy tools that really allowed their network to come online. So still in its early stages, but we're already seeing widespread adoption, and we're seeing a lot of use already from what Massachusetts has already done. If we move on to the next slide, and I know we're a little pressed for time, this is clearly engaging the population is vital. Engaging members, we can build it, we can create great access, we can think of programs, we can think of customizing the programs, but obviously if we are not engaging members, they're not going to use what we've created. And so we recognize that this is such a vital part of not only what we roll out and what we bring to the population, but we really have to think about how do we engage populations with, the right mix of, email, if we have email addresses, phone, text, community outreach, showing up at school events, thinking about other community events and where members are typically showing up or getting care. In other words, we've got to attach a lot of the engagement that we're providing to where members are already going. If we think about customer service lines, if we think about nurse or triage lines, if we think about often your health plan's website, where are members typically going? Find a doctor is typically at the top of the list. We have to attach ourselves to where members are today. And if we can extend and make telehealth a part of that existing journey, we can reach them in ways that are going to really resonate with them from an education, from social determinants, from language, from ways in which we think this is really going to resonate with them. Even nurses that are out in the community or social workers out in the community, this is where engagement is really going to lead to the right adoption, the right usage, and appropriate utilization that's going to help drive down the costs that we're also concerned about. And last but not least, if we move to the last slide, clearly we need to measure the impact of the program. We need to have we arm you with the right tools around reporting and analytics to help you understand not only the ROI, but to think about success tracking for your program. American Well delivers customized reporting tools to really help you measure the impact of the programs you're delivering, reports that you can easily track in terms of enrollment and utilization, prescription, diagnoses, cost savings, and other recommended key performance indicators that map the positive business outcomes for you and your organization. So we have the ability to really take a look at what's working, collect data, really dissect the data, and really help us better understand what's working, what's not working, so we can optimize it and really help you communicate the benefits and the results of what you're doing, importantly to your leadership. So I'm going to stop there. I know that was a lot in a very short period of time, but we wanted to leave for both Brian and myself about 10 minutes for questions that might come from the audience. So with that, I'm going to stop, and I don't know if you're going to open it up or if Webster, you're going to open it up for questions that may have come in from the participants.
Absolutely, and thank you so much, Brian and Danielle. We have had a few questions come through. So let's see. Our first question is, Wyoming Medicaid allows any enrolled provider to provide telehealth to any site, including home. We pay the same as face-to-face for any code except for group therapy. We have no MCOs, all are FFS. I guess that's not a question, that's just a comment. And then our next question is, do you know which entity in Delmarva region is using your services? They just signed a contract with both Maryland and Virginia Medicaid.
What is the question? Why the name of
I'm sorry, you cut out. What was that?
the name of the? If you could repeat the question, I think there was an organization that was mentioned, and I want to be able to address the question.
Yes. Do you know which entity in the Delmarva, DELMARVA region is using your services? They just signed a the person who submitted the question said that they just signed a contract with both Maryland and Virginia Medicaid.
Well, I mean, in the Maryland, Virginia market, we're talking about health plans. We work with Care First, probably predominant. Obviously, we're working with like Sig the provider supply. In cases, it's predominantly we are a local provider urgent rural health service group. In terms of health system agent, also extend a lot of specialties. American Well's health system partner. We've got partners. There is really an opportunity for us to tap into our health system partners who can also take their providers and avail them to our health plan partners that happen to be in a given geography. Other question?
Great. Yes, and then when assessing the effectiveness and economic impact of telemedicine, what are the one or few measures that help plans most often? For example, reductions in ER use?
Well, I think, I brought it up a little bit in the beginning when I talked about the Moores Children's Hospital in Florida, and they've got a published case study. And we've got, probably more than a dozen different case studies that actually speak to savings and ROI. And they tackle these issues. I mean, certainly emergency room avoidance. And there's enough data and studies now that say with offering telehealth as a viable, accessible option, we do have data now that shares that ER costs can be, if not, it can be significantly decreased. That would probably be at the top of the list. When we talk about some other factors, certainly outcomes, for satisfaction, retention, attract members into the program. We've got a lot of different studies that will actually share other attributes and other savings that both through hard dollars as well as like I mentioned, member satisfaction and noticeable changes in outcomes. So, unfortunately, we don't have the time to share all of that. But I welcome anyone to reach out to American Well directly, and we can share some of these case studies.
Great. And then does CMS accept telehealth diagnosis codes for risk adjustment purposes?
Brian, do you want to take that?
I do not actually know the answer to that question, but we're happy with that.
Okay. When assessing effectiveness and economic impact, is there a source of benchmarks or expectations? How do we know what is good?
Well, I think it's going to listen. That's a great question, and it's going to vary dramatically from plan to plan. Obviously, cost is going to be a big factor, and so we are going to take a hard look at where would members be going if telehealth wasn't an option. Are they going to do nothing at all? Are they going to show up at the wrong place at the wrong time? It's not just the emergency room, but perhaps other higher cost settings. And so there's been a lot of obviously a lot of studies that have shown if we can provide a tool and capability that are going to really drive members away from these high cost settings, there is going to be an impact. A good way, of course, to measure that is by utilization, of the actual tool, of the actual, digital solution that you bring to your membership. Appropriate utilization, I should say. And so, we see that varies dramatically to the slide I talked about with engagement. A good program, your members need to be made aware. You need to communicate with them, and it's got to be on an ongoing basis. You have to meet them wherever they show up so they know this is a viable option. So utilization and engagement are going to be two very big factors. Again, it's going to widely vary, but we've got partners that are seeing 2, 5, 8% of their population actually engaging in telehealth. That's dramatically impacting cost and cost savings in particular.
Great, thank you so much. And then Brian and Danielle, if people did want to follow up with you or answer any questions, how can I get in touch with you? Would you mind sharing your email addresses?
Yes, I mean, I would just say if there's an easy way to do that, Devin, maybe there's a way we can put it on the screen, or we can have a pretty long email address. But for both, and I want to be clear, American Well and Sellers Dorsey are partnered together. We've been sort of taking our collective assets and intelligence and really trying to, at the end of the day, do good in the community and partner alongside Medicaid plans across the country. So if there's a way, Evan, that you can share our email addresses, you know, that would probably be great for everyone that's participated today.
Absolutely. I know American Well, you guys will send out a follow-up email with all the information. So we'll make sure the attendees receive your contact information that way. Well, I definitely want to thank again both Brian and Danielle and the entire Sellers Dorsey and American Well teams for coming together for today's webinar. And thank you all to the attendees for joining us today. I thought hopefully you enjoyed all of the content, and we hope to see you again on one of our next webinars. Have a great day, and then have a great Thanksgiving. Thank you all.
Thank you
Bye-bye.
very much.